Wonderful. It's great to see everyone online. We're really excited to kick off this session together today. Really welcoming our Olathe schools colleagues, our Marillac and KU Health System and KU Med Center colleagues, and then our Telehealth Rocks colleagues. Really fortunate with some of our telementoring work. So just getting us started, I want to send a few reminders to everyone online with us today. Your microphones have been muted, but please do use the chat or unmute yourself to ask questions. We really do want to hear from you with our Q&A sessions today. We really appreciate when you're able to keep your camera on. It's a-okay to eat with us. I know some folks are joining us over their lunchtime, but if you're able to keep the camera on, we'd love to see you and engage with you. And then finally, make sure you do type in your first and last names so it's visible on the Zoom screen. That really just us today. We do share a project disclosure statement. So just we have no relevant financial relationships with the presentation today, and we will not be discussing any unapproved or investigative use of commercial products or devices. We do, with our mitigating potential bias, we're presenting the best we know today. So our information may evolve, and so we just include this reminder if folks are looking at the videos or those sorts of things. Just know we're sharing the best that we know today. So no, with no further ado, it's really my honor to introduce two child behavioral health champions in our metro community and two leaders at Marillac. We'll be hearing from Dr. Sharon Kane. She's a child and adolescent psychiatrist and director of the Division of Child and Adolescent Psychiatry at KU Medical Center, and Dr. Mitchell Douglas. He's the medical director at Marillac. So welcome, and we look forward to hearing from you.
All right, good morning. I'm going to introduce myself, and then I'm going to pass over to Dr. Kane to start with some questions. Dr. Kane, does that sound okay?
Yes, sounds great.
So I'm Mitchell Douglas, Dr. Douglas. I'm a boarded adult and child psychiatrist. I also did residency in pediatrics. Moved back to the Kansas City area in 2009, worked at the Wyandotte Center, PACES from 2009 through 2015, community mental health, got to see lots of kids in that environment, and then came to KU Family in 2015. And I've been the medical director here since 2015. Really excited to talk and try to give you as much useful information as possible in the next 45 minutes. I'm fully aware that things are not perfect in the world of child and pediatric mental health, but I'm gonna try to get things, tell you as much as I know right now to improve the communication between us and, well, right now, the Olathe School District. Dr. Kane, and Dr. Kane's actually my boss, so a little nervous. So we'll see
I don't know about that, but okay. Well, thank you for that introduction, Dr. Douglas, and thank you, Dr. Nelson, for your nice introduction. And so I'd like to get right started and start asking Dr. Douglas some questions that will be helpful to everyone. So first of all, for your overview, would you please tell us a little bit about Marillac?
All right, so Marillac is an inpatient child psychiatry hospital serving kids age 4, and I have a 4-year-old on my unit right now, to age 17. If they're not 17, if they're 18, that's an adult, and that's a different facility. Just to make sure that really basic stuff that keeps coming up. We are a KU facility. I am a KU physician. We are KU. KU acquired this property fully in 2017. So we're not staffed by KU, but still Marillac. Marillac is just the name that we've kept on to because it has great historic significance, but this is a KU facility. We are an inpatient child psychiatry facility and an acute facility. In the past, we had residential beds. So when I first got here in 2015, our entire upstairs were for kids to stay for 6 months or 3 months or 9 months or stuff like that. We do not have any of those beds right now. We are only acute beds. So our average length of stay is actually 4.1, 4.2 days. There is no exact set time for how long a child needs to be here. Just like every other bed in the KU health system, we evaluate the kids, we figure out their needs, we try to get them better, and then when their condition is better and they're safe, we look towards discharge. Well, on average, it's about 4.1 days. When I first got to Marillac in 2015, there were 2 psychiatrists. I was one of them. We grew from 2015 through 2019 up to 8 child psychiatrists and running a census of about 60 to 65. In 2019, going on to 2020, we hit COVID. And with COVID, we went from having 2 kids in a room to, for infectious disease reasons, went down to 1 kid per room. And so then our census dropped pretty dramatically into the high 30s, low 40s. We're emerging from the COVID pandemic and looking to increase our census. Our census average now is running in the mid 40s, looking at capacity to increase in the months and 12 to 14 months to come into the more significantly going into the 50s and a little bit higher. And I know I talk fast. Please, Dr. Kane and other people monitoring, give me like a little signal or something if I'm going too fast or too slow. Okay. Bear in mind that as an inpatient child psychiatry hospital and a pediatric facility of any type, with a census running in the 40s and 50s, we are the largest freestanding pediatric facility of any type in the state of Kansas. So we're kind of getting up there in terms of where we considered a mid to larger side in freestanding inpatient child psych hospital. I'm going to keep going. I want to make sure I get the really important information to you guys. Am I doing okay? I'm looking for facial stuff. I'm looking at you, Mike. All right, he's paying attention. What happens here? So we're an inpatient child psych hospital, averaging stay 4 to 5 days. There's really basically 3 big places people go when they're here. We started in 2018, 2019, something we call our insights unit. So the second floor, we took that residential beds, we remodeled them, they got a new floor, we made it a little fancier, and we made it for a unit only for kids dealing with depression, suicidal ideation, or after a recent suicide attempt. All the kids on those units are going to be 12 to 17 years of age. They're going to have the cognitive skills to be able to do a little bit more advanced CBT work, and they're not going to have significant aggressive behaviors. So that's anytime you have that 12 to 17-year-old and they just overdosed and got medically cleared in an outside hospital, or they're having recurrent worsening suicidal thoughts, and they really want to get better, or maybe they don't want to get better, but they're not aggressive, and they can kind of think through and do some basic CBT stuff, that's where we want them to be. We've tried to set up our programming, our expressive group therapies, our individual therapies to be specific for that population. And the idea being it's a little easier to deal with depression, suicidal thoughts if you're with a cohort of other patients dealing with similar stuff and they're not dealing with psychosis, mania, substance withdrawal, stuff like that. Does that make sense? On our downstairs, we have a unit special for kids age 4 to 10, 11. And then we have another unit for kids dealing with psychosis, mania, conduct, everything else. So that's kind of when people show up. You're a 6-year-old, you go here. You're really depressed and sad, you go up to our insights unit. You're not those 2 groups, you go to the 3rd unit. That's kind of how we divide it up. When people are here, they're going to be seen every day, Monday through Sunday, weekends included. Doesn't matter what your insurance status is, by a child psychiatrist. You're going to be seen on intake by our pediatrician. We have a full-time pediatrician here. We have multiple nurse practitioners whose only job is the pediatric care of our patients here. They're not just swooping in the morning, laying eyes and leaving. They're here all the time. This lets us take care of pretty medically complicated kids. So our type 1 diabetes, we have a really kind of a tight curriculum for them. Oh, I see questions. All right, great. I love questions. We can take care of type 1 diabetes. We are not specifically designated for acute eating disorders, but we certainly see lots of patients with disordered eating, and we really are pushing our ability to care for those medically fragile patients. So we see lots of that. So we have lots and lots of pediatric support. I have an entire team of pharmacists to make sure the medicines are safe, and they're here on site all day long, checking meds, consulting with me. Every patient's going to be seen every day by their own individual therapist. We also have a team of PhD psychologists, which are also involved with care. In addition to that, we also have a whole group of expressive therapists that do music therapy, art therapy, drama therapy, well, not drama therapy, music, art, recreational therapy, other expressive group therapies. That's kind of the big picture, kind of what's going on here.
Can you
How
just
many
say a
beds?
little, can you say a little bit about the number of beds, and then we'll go on to the next question?
So when we're looking at each unit's a little bit different. Upstairs, we're maxed out right now. For insides, we'll have 24 beds, 2 kind of units of 12. We have 6 beds designated on unit C for our little ones. Certainly. Oh, we're gonna get them. I love this.
And that question we'll get to later.
Yep, that's a great question. And then our other units for everyone else is going to be looking at 8 beds per unit, so another 16. We do have flex capacity because we were running in the 60s, same building, same number of beds 26 months ago. So right now we're just in the process of getting our staffing back up new where it needs to be so we can start utilizing a higher bed capacity.
Okay.
So that's,
Dr. Douglas, can you describe a typical stay with Marillac, and is there a daily schedule?
So what's interesting is my initial response, there's no typical stay. There actually is a typical stay. And that's actually a big training point for when the med students, so we're an academic training hospital. We have med students, third-year med students, fourth-year med students, second-year adult residents, child psych fellows, pharmacist residents, psychologies, pre-docs, post-docs, all those people. They're all around here. And one of our big training points, especially when the kids come to the insights unit, they're there for about 5 days. We set up the curricula to be a 5-day program. And it's always really amazing. They show up on day 1, they have major depressive disorder, recurrent severe, with or without psychotic features. They want to be dead. And the med students are typically like, this looks horrible. This is a sad kid. They've been abused. Oh, that's day 1. They do group therapies. They advance off unit. We make sure we're clear on the diagnosis. They start doing therapy. They get off their phones because they can't bring their phones here. They start talking to their families. And about 80% of the time by day 3 or 4, they're feeling better. They're wanting to go home, and they're discharging on day 5, 6. It just happens over and over for those units. The little ones, 4 to 11, it's a little bit different, more of a variable course because it's a variable presentation. We see a lot of ASD with aggressive behaviors on that unit. It's a little bit harder to treat, a little bit different course, a lot of trauma, just lots and lots of trauma. On the other units, if I'm dealing with psychosis or mania, it may take a little bit different modalities each time. Is there a daily schedule? Yes. We actually just revamped our schedule, which will roll out, or the revamped schedule on the 23rd. We're looking at making sure we have at least 2 to 3 group therapies a day. We're going to be doing more cinema therapy. But big picture, there's a posted schedule. You wake up, you brush your teeth, we do a group in the morning, you do another expressive group, you see your doctors, you do another expressive group, you have lunch. Typically, there should be another expressive group in the afternoon. You might go to the gym. If it's not 30 degrees outside, we do, actually, as of 2 years ago, we do have an outdoor space that's fully fenced and secured. So when the weather is in our range of 55 degrees to 90 or something, the kids go outside. The winter time's a little harder because of the laws and regulations about that. They meet with their family. There is visiting time for the family. They're going to work with their therapist. They're going to bed around 8 or 9 o'clock. They go to sleep. That's kind of the daily schedule. Now, is there some variability to that? Yes. Sometimes it's 2 groups, sometimes it's 3 groups, but that's the general shtick. We have a schedule printed out from time of waking to time of sleeping with activities throughout.
Thank you. And one thing I might just mention, I think you mentioned ASD being something you see in the younger children more frequently.
Well, so we see obviously ASD in all the populations. I mean, the classic.
I might just ask you to clarify for everyone, just make sure everyone knows what ASD means.
Yeah. So we're talking about individuals with autism spectrum disorder. So we will either see a child who has not yet been diagnosed with autism, but has significant disruptive behaviors in the younger population. Classically, what we'll see, maybe on our a little bit of older units, you have that, classically, you have that child who's been doing very well in the school and home environment. They hit 12 or 13, puberty strikes, they're bigger, they're stronger, they're heavier, and that same level of aggression now is really dangerous. And so then the family doesn't know quite what to do, and so they end up with us, and we try to get them better.
Great, thank you. Okay, now regarding admission, can you describe the admissions process and why might a child not be admitted?
Okay, so about half of admissions to Marillac occur via the emergency room or transferring hospital. The other half come in terms of patients who are walking in our front door. And I'm going to sort of segue this question because I really want to make a big point. You guys are all like Olathe school counselors or principals or mental health professionals in the schools, right? That's the right. Okay, I'll just take that as yes. A big concern that I have is just making sure you guys are clear. If a child is overdosed, they need to go to an emergency room. If a child is in complete disarray, they're destroyed the classroom, you have 5 police officers in there, and we're not quite sure what's going on, that would be looking at possibly going to an emergency room setting to be medically stabilized and cleared prior to transfer to our facility. Occasionally, we've had some challenges when there's a kid who we're not sure what's going on, and they just kind of sort of get driven over, and we're not sure what's going on, and they're not stabilized. So if they're walking in our door and we hear, oh yeah, they overdosed an hour ago, we are not in an emergency room. I can't do a stat lab. I can't, we're not set up to secure an airway. So that patient's just going to right back on the ambulance and go right back to the ER. So that's a little off that question, but I think it's important you guys hear. If you're in acute distress, this kid just walked in your office and said they overdosed last night. They overdosed in 24 hours, but they look fine. I don't care. If I hear overdose and it's been recent, I need to get that medically cleared, because there are some things you overdose on, like Tylenol, for instance, where you'll overdose, you'll pass out, you'll have an upset stomach, and then you'll look okay the next day, but it'll still kill you 3 days later. So they still need to be acutely medically treated. And oftentimes kids don't know the difference between ibuprofen, aspirin, and Tylenol. They took a pain pill. So that's why it's really important for them to see an emergency room setting, get the appropriate urine drug screen, get the appropriate toxicology evaluation. That just being clear on that, because that might be stuff that you might be seeing as a social worker in a school setting. When kids are coming in as a walk-in, they need to be brought in. You need to make sure that there is a parent or a legal guardian who is going to be allowing us to do the interview and consenting to the evaluation. They're initially going to be triaged by a nurse. Vitals, did you overdose? Do you have type 1 diabetes? Or is your blood sugar 500? That type of thing. Then they're going to be seen by a therapist who's going to do the initial admission evaluation. On average, about 80–90% of the time, patients end up being admitted to our facility. And that's generally because people don't like to spend a couple hours being evaluated for psychiatric hospitalization unless there's something really big going on. It's generally not the best time. The other question is, why might a child not be admitted? So I was texting with my head of admissions about this talk and what to say. And she wants to remind you guys, probably the number one reason why why children may not be admitted is that the family's coming over, sometimes from a school district or referred by a school district, because they don't know that this is an inpatient facility. So perhaps the outside therapist or pediatrician, or maybe the school counselor says, oh, I'm really worried, you need help, you need to be assessed. So call the parents up, sure, okay, fine. What, Marillac? Okay, fine. This is what I need to do to get my kid back in school, it's fine. They show up here, we're in the process of doing an assessment. The assessor goes, okay, well, we're trying to figure out if you need to be admitted to Marillac. And we're like, well, to your outpatient program? And we're like, no, to our locked inpatient facility where you'll be spending the night and probably here for 4 to 5 days. And then the family says, oh, heck no, that's not happening. And we're like, the school thinks you might be suicidal. And the family's like, no, that's not what we're doing. And they walk. In the state of Kansas, unless it is very, very restrictive on the ability for a physician, if the family wants to take that child home, for me to take away that parent's rights and have that patient be admitted against the family's will. I have to put that patient in police protective custody, and that's a very rare occurrence. So that would be like a reason why a child might not be admitted. Other reasons, the patient, the criteria we're looking for is the patient in acute danger to himself or others, first and foremost. Is that behavior going to be changed by a psychiatric hospitalization? So other thing that can come up, if they come in and they're not suicidal, just had a bad day, and they're like not depressed, but they need outpatient services, they may get referred on to outpatient services. Rarely it can come up where a child has chronic suicidal thoughts and that's their baseline state. Then that leads to some question, and they've been hospitalized many times. There may come a question whether or not the hospitalizations are helpful, or do they need more intensive outpatient services as well? Generally, those kids get admitted because we want to make sure the kids are safe. Does that help? Does that make sense? I wish people were, okay, well, someone type something. Just, I don't know, we're having for lunch. Okay.
Well, the next question is kind of related too, so that might help, but it's about referral. So how can a school refer a child who might need inpatient or outpatient services, and what information is helpful to provide?
So 913-574-3860 is the number for admissions. That's 913-574-3860 is Marillac inpatient admissions. What was that number again? Yes, that's 913-574-3860. You can call the admissions line. We can't divulge information about a patient here, but we can always listen. I just kind of confirm with my admissions person about that. I'm like, hey, I'm doing this talk. And they made a point. You're concerned, you can call. That's the admissions line. It should be staffed 24/7. If it's calling at 3 in the morning, it might be a slight delay. I doubt you're going to be calling at 3 in the morning because I don't know what you're doing calling us at 3 in the morning, but okay. But you can talk and tell us what's going on. Information pertinent to why this patient needs psychiatric admission, like suicidality, like risk of self-harm, like risk of others, like the threatening to harm others in the school, like the presence of means of harming self or others, like a firearm. That all would be very relevant and important information. That said, the outpatient stuff, Dr. King runs the outpatient. She can talk about that in a second. The other big thing is kind of like what information is helpful to provide. You got to get the family involved. And that's the other Marillac admissions. That's giving the direct line, giving the inside scoop. Where was I? You got to get the family involved. I need family consent to admit the patient, or guardians, not family. I need the guardian's consent to admit the patient. I don't need both parents. I need at least one legal guardian. So dad's on a field trip, but mom's present, great. They need to be up to speed with what's going on. We do have that problem, which I kind of alluded to before, but a different version is the parent brings, how much do you use? So how much do you base on parents? That's a great question. So what can happen is the problem I see most often is the therapeutic drive from the school or a pediatric office or therapist office, but I'm talking just school counselors, from the school to our facility. The kid's in your office and they're suicidal. So mom gets called, mom picks them up. They end up going over here. Although that's a big decision. We'll talk about that in 1 second. Put a pin in that. They come over here, and by the time the kid gets here, mom's like, I don't know. Kid's doing great, AB student doing fine. And we're like, well, Tyreek, why are you here? What's going on? And the kid's like, I don't know, I'm doing great. And we're like, we don't have a lot. So that's why I gained that information from you guys to help us with the evaluation process. Because if I hear, well, according to this information we got from the school, you were telling everybody that you were planning on killing yourself today. Well, yeah, okay. And then the mom's eyes are gonna get a little big and like, oh my gosh, freaks out. We have to process that with her and then try to figure out what's gonna be best for the child in that family. Happy on school. Does that help a little bit? How much bears on parent disclosure versus evaluation of the child? Typically, the child tells us more than the parent. We see both versions of that. Generally, if I was going to think about that, whatever is going to be most dangerous is going to take triumph. The kid's like, I'm suicidal, but the mom's like, nah, not really. the kid's suicidal. If the mom or parents showing up there, here's the note, and the parent said, kid said he's going to kill himself today, and the kid's saying, I'm fine. I'm taking that seriously what the parent says. Please describe a scenario where Johnson County Mental Health would be appropriate for referral as opposed to when Marillac would be the best choice. So I'm picturing you guys, Marillac is going to be inpatient child psychiatry. So I'm looking at this in terms of Marillac, the inpatient child psychiatry, not talking about KU outpatient child psychiatry services. I'm putting in the lens of this kid is sick. You are worried that this kid is going to be dead or harm someone else in the next short time period. There's some questions about what that time period should be, hours, days, week, I don't know. But you're worried that this kid is going to decompensate quickly, then we're talking inpatient. If you're worried that this kid is doing poorly and that their depression is getting worse and they need services, then you're talking about whatever your local community mental health center is. Dr. Kane, I should stop talking. You talk about outpatient. You do you.
Okay. Well, we do have outpatient services here, and Johnson County Mental Health also has outpatient services. So if the problem is not acute, it's not urgent, as Dr. Douglas said, then outpatient services may be appropriate. And you do have, parents do have options for that. So I would imagine you would talk with the parents and let them know your concerns, and then the parents would probably choose what is most appropriate for them, what they want. But I think either they could seek services with Johnson County Mental Health, or they could seek services in our outpatient clinic or with other outpatient providers. A lot of times, if patients need a lot of services, if they need wraparound services or in-home therapy or may need residential or a lot of support, then they may be more likely to seek services at the mental health center, because the mental health center does have the ability to put those other services into place. And we can for you, I think we could put in the chat both the inpatient number to call if you need to refer a patient for inpatient, and then we could also put our outpatient service number for you in the chat if you'd like to have those for reference. Okay, so let's go on to the next question then. So regarding discharge plan, Dr. Douglas, is there a typical discharge/safety plan? And how is the plan created and who has input?
Okay. Oh, I want to throw one last thing for the admission stuff. I mean, make sure we don't worry about insurance status or documentation status for Marillac admissions. So I just want to make sure that should never be a barrier to a kid needing care. Make sure.
Which may be different on the outpatient basis.
Right.
In the outpatient clinic, usually when it comes to outpatient services, the university or the hospital health system usually tries to help people find the most appropriate services that fit with their insurance, so they don't end up with a huge bill.
But if you have a child in your school district and they need acute help and their documentation status may be unclear, then send them on to, we don't care. Just let's get the kid help. Okay. Ooh, Kirsten's moving back and forth. Okay. Discharge safety. Everyone, we have a sort of evidence-based safety plan that's developed for every single kid here. It's done with the therapist and the patient, and ideally with the family. Oftentimes it takes 2 or 3 hour-long sessions to get the sucker done. It's working through the biggest thing we focus on, which we'd love you to continue to support with the family, is going to be means restriction, which is one of the big ways we can actually, which is an evidence-based approach to actually reduce kids from dying. So, if you're looking at, Christy has made a scary face. Oh no, you okay? Okay. Just giving you guys info. If your child is at acute risk of dying by suicide, if they attempt suicide with a firearm, the likelihood of death is going to be 80 to 95%. So making sure firearms are locked up and not accessible to the patient if a kid's acutely suicidal makes a lot of sense, and that needs to be supported with the family. And that definitely would be helpful if you're working with that family. Get those firearms out of the home or locked up, whatever way you can, and that's just trying to keep kids from dying. Also means restriction in terms of locking up meds, as well as acutely sharp objects. But again, there's this sort of debate that can happen. I know I'm preaching to the choir about, well, if a kid's going to die, die. No, if we means restriction is a strong evidence-based intervention, which can really help kids like stay alive. When they have that passing thought of suicide, when they're at their worst state and they're thinking about dying, but they don't have access to a high lethality means, they don't end up dead. And then they can get help, they get better, and they can keep living. The safety plan is also going to be looking at outpatient referrals, getting them into other therapeutic services, and what to do if and when suicidal thoughts return. We are fully aware that the kids are not going to be perfect when they leave. If I have a kid with major depressive disorder, severe, without psychotic features, we're going to get them better and safe, but they're still going to deal with depression and recurrent suicidal thoughts. They need to have skills in place for what to do if those thoughts get worse. That's presentation. What else? Is there a wait? Okay, is there a wait list for outpatient? Oh, I'm sure.
Yes, there is. In our clinic, I don't know what it is right now, but it often can take several weeks, kind of a couple of months. But it does vary a little bit, so it depends on the time of the year. Tends to be seasonal.
There's a weird thing with inpatient child psychiatry and somewhat outpatient child psychiatry. Our census will vary by 50 to 75% based off the season. You come in the summertime, our census will drop to 15 to 20. The kids are not stressed by school. They also don't have school counselors and social workers and therapists like you guys and teachers and principals checking out the kids and figuring out if they're doing well or badly or need help. So we will drop over the summer, school will start up, and I've been here for 7 years. Every 7 years, come late August, early September, we will climb 25, 30, 35, 40, 45, just like clock. School ends for the Christmas holiday, the seasonal holiday. Kids are still depressed. We know holiday seasons are tough. Census drops. School starts back up. A week later, we skyrocket back up. It just is. Which also vaguely ties into what Dr. King was saying about time to get in to see people. Generally, it's easier to see people over the summer than other times of the year. So that's a KU. Does KU do outpatient family therapy? Oh, wait. This may be for later. Those kids are discharged that aren't connected to a med provider and have trouble getting a new patient appointment before they run meds. How do you advise or support parents to get meds refilled? We just changed our policy. Literally, I kind of changed it 4 or 6 months ago from extending number of refills generally to 60 days. We want patients to be seen. What's the challenge in this situation? I keep focusing on depression, suicidality, because and we see more than just that here, but that's kind of my passion. 30 days after discharge from a psych hospital are the most dangerous time. That's the time when kids need the most. One second, I will call. 30 days after discharge is the most dangerous time after psychiatric hospitalization. So that's time we really want to make sure they're on their meds, but also being seen as quickly as possible by a therapist. We try to get kids into bridge clinic appointments within 7 days of discharge. We are just trying to get a navigator person, someone to check in on our acutely ill patients and follow them immediately after discharge. Things to work with when you're talking to families, 50% of the meds I prescribe, pediatricians will be willing to continue but not alter. So most pediatricians in the community will continue sertraline, fluoxetine, maybe Cymbalta, stimulant medications, alpha-2s. They probably get a little worried once you start talking about atypicals and SNRIs. But most of them should feel comfortable with 3 or 4. So if they're unable to get in to see a child psychiatrist in a timely manner, sometimes it's helpful to work with the families to see if we can get them in to see their outpatient pediatrician. Is it the best system? No, it's not. But that's something we're definitely fighting.
Okay, let's go on to next support. And how can school nurses and counselors help with the transition from inpatient back to school?
So this question, I think, is kind of challenging. It's really hard for you guys. So one, on my world, be kind of careful. Lots of families are resistant to telling the schools that the patient was hospitalized. I'm always trying to encourage the families to say, you need as much support as you can. Your kid was in a locked inpatient psych hospital because of XYZ, right? The most dangerous time period is going to be when they leave the facility. So you should be asking and getting all the support they can get. But still, the families will oftentimes are very resistant to letting them know, or that's not their business. It might be helpful, I'm just brainstorming here, to encourage the families to be aware that, what happens with you and a school counselor therapist can be a confidential conversation. It's not going to be spread throughout the school. And to make sure that the families know that, because I hear lots of hesitancy about that disclosure. And that's a barrier, because if I don't have that permission from you guys, if I don't have that permission from the family, then I can't coordinate care. And then you guys are upset because, like, Jimmy was suicidal, he went to the hospital, he came back, and we have no idea what's going on. And you can call up here and ask us, and we can't say anything because we're not allowed to. That's the hard part. Maybe yeah, go ahead.
I guess if the parents, if the parents agree, and that's one thing that our therapist can let them know, that if they do choose to share, that one thing that I think could be helpful is to let maybe if the counselors at school or nurses or teachers, whoever you decide, could perhaps touch base with that student when they return, maybe on a regular basis for a certain number of times, just to check in, just to see how they're doing, and maybe check with the teachers to see what the plan can be to help them with their schoolwork, so that maybe they aren't as stressed about the work they missed during that time. So I think those are the main things.
Yeah, and we try to actually really directly going back to suicidality, we try to incorporate, if possible, into the safety plan. If you have suicidal thoughts and you're at school, what are you going to do?
Exactly.
Is there a school counselor that we can identify that needs to be know of this and not be surprised, that you can reach out to and talk to? And can you get a hot pass or some sort of special permission to make that actually something that's possible?
Right, and especially if it's a student that if it's a patient that's had some school refusal or school phobia, then it might be really helpful to have a certain person that student touches base with when they return to school, so that, to help them feel more comfortable and help them return. So those are some thoughts.
Other random thoughts. I got a group of people who are doing the work every day in the actual schools with the actual kids, and you see lots and lots of kids, especially kids coming out of the hospital environment. Encouraging them to maintain their abstinence from all substances is helpful. If you're depressed and they haven't smoked weed for a couple days, then they're feeling better. They're going to be tempted to go back to smoking weed, making sure you're clear. Do not go back to smoking marijuana. It's going to make things worse, not better. I'm just being clear, because I know these kids are smoking up a lot. Two, we're seeing a whole bunch of kids in the last 9 to 12 months with, actually going back to the weed thing, we're having significant worsening in their mood and the psychosis, secondary to the higher percentage of THC in the dab that they're doing. So really encouraging them to maintain that abstinence, which occurs while they're here. And if you go back and they start hitting dab and they haven't done it for 5 days, they're going to decompensate quick. And then they end up being rapid to readmit. But three, we are seeing a whole bunch of kids come through here with pretty significant fentanyl addictions. So we are actually having to, I'm doing specialized training, our whole department is on further training in addictions. We're seeing lots of fentanyl come through. We are seeing lots of people on PERC 30s or M30s, whatever you want to call it, in your school district. We're doing more and more scripts for kids leaving with Narcan. So continuing to monitor, ask about that, and making sure everyone's fully aware. If they're, I don't know how many times you had a Narcan in the Olathe school district, but it's a distinct thing that's changed that I observed in the last 12 months that I wasn't dealing with in 2015. And they're having a hard time coming off. I see these kids come in and they're hooked on perks, and then on PERC 30s, which is really fentanyl, and they're still craving 6-7 days out. And we're talking about 16 above, Suboxone and medication management stuff. It's rough. Off topic, but I mean, what's going to help the kids? That's some real.
Yeah, very important.
Yep.
Okay, and next after a stay, how are families connected to supports after the child leaves? What if a child doesn't have an outside therapist, psychologist, or psychiatrist?
So we have 2 people on staff whose full-time job is just literally not doing the safety plan, is just calling the family and trying to get people appointments for stuff. Everyone before they leave, I mean, they have a piece of paper with the appointment set. One of the challenges is Johnson County Mental Health, other mental health agencies will not allow us to schedule an appointment for a patient. The appointment has to be scheduled oftentimes by the family themselves. So we can say, call this number and set up an appointment, go to this walk-in to get a walk-in assessment, but we cannot, so oftentimes we're not allowed to make the appointment because that's the policy of the outside facility. So again, this question leads to the problem of the amount of illness is this, and the availability of resources is this. And that's the hard part. The biggest solution, and I think the trick with that, is making sure the kids who are in the most acute need get in quick. And so that's one of the things we're trying to solve. Because, I mean, it should be a triage process. These are kids. Suicide is, depending how you splice the numbers and the age, but if you look at 12 to 17, it's be the 1 or 2 cause of death. So in my mind, that should be a really top priority.
Okay, and next.
Re-entry meetings. Wait, I just want to read this. I'm sorry.
Okay.
Wraparound. Blah, blah, blah. We often have re-entry meetings. That sounds exciting. There are families that come to us to ask for help to get access to wraparound services. So you're asking about further services outside Johnson County Mental Health for wraparound services, and you're not in Wyandotte, so we're not talking about Wyandotte Center PACEs. So a little outside my purview, because I'm not the discharge planner, certainly it'd be helpful to be aware there are an increased number of IOP programs in the Olathe area. You guys probably know about them. You know, Cottonwood now offers a juvenile adolescent IOP program. There's some other IOP programs around. You ever make the...
Does everyone know what an IOP is?
Yeah.
That stands for. Okay.
And we're trying to set up an IOP here. It's not set up yet. It's supposed to be going now, and it's not. So I'm hopefully the next time I do something like this, I'll be able to say, and we have greater outpatient services and a fully staffed IOP. Do you ever make the discharge plans coordinating with the outside mental health professional to ensure? Sometimes it would be, I'd like to say we do it every time, but we don't. But if there's what is an IOP? Intensive outpatient program. So in the continuum of care, and this is kind of one way to think about when you're seeing these kids, you want to make sure the kids are in the right continuum of care in terms of their mental health needs. So you can go from, you know, Maurice has got a little adjustment disorder. He's kind of hard time adapting to school. He might work with a school counselor once a month. Oh, he's actually got pretty significant depressive symptoms. He needs to get support from school counselor and outpatient therapist. Oh, he's pretty sick. Oh, he's getting to see a psychiatrist, start some meds, weekly therapy. Oh, he's really sick. He's starting to have his thoughts about self-harm, but he can be safe at home. IOP, intensive outpatient program. Every day after school, 4 days a week, he goes and does services from 4 o'clock to 7 o'clock. Oh, he is barely safe to leave to be at home. Some places offer partial hospitalization. We do not have partial hospitalization at Marillac. We used to, we don't now. Some kids might do a partial hospitalization. Oh, these kids, they're not safe. They're not safe at school. They're not safe at home. A home is not a hospital. Mom, dad can't watch the kid 24/7. They're, you know, they're not set up to be a hospital environment. They're in a hospital. And so our goal is trying to figure out where in that continuum of care a kid needs to be. Acutely sick, they're here. Partial, IOP, intensive, you know, therapy twice a week, therapy once a week, maybe a little sports once a month.
And then on communications, what is the best way to connect with Marillac? How can schools get information after a child's stay?
They can make sure that the family has given consent to release information. And that's the biggest challenge. I don't have the best answer to that question. What is the best way to connect with Marillac other than the multiple numbers that we've provided? That would be those numbers listed there. don't have a bunch of fun, interesting things to say about that. I do want to show you here, and I literally was just in the admissions room saying, hey, we're doing this call. And they're like, yeah, it's, we get calls from school counselors all the time. It's absolutely appropriate to make that call.
Mhm. Yeah, I think you're right. I mean, I think calling, giving families, parents the numbers to call and information, but also I think this communication, I think these televideo sessions that we set up really kind of came out of this question, because I think we heard that from some of you as how do we connect? How do we get information about our students when they return? How do we help them? And we were struggling with the fact that we often did not have permission to be able to respond, be able to give information. So we thought, well, maybe this is one way we can connect and share information and get a dialogue going back and forth, and perhaps help you know more about what we do and learn more about what your struggles are, and help each other through this process.
What else? I'm just thinking stuff. What maybe, and if you're working with kids after they come out of here, I mean, I've looked at our Yelp reviews, and we don't always get a 5-star Yelp because we're an inpatient child psych hospital. It's hard to get 5-star Yelps. Maybe focusing on kids, blah, blah, blah. They liked our tacos, they didn't like our tacos, or like it was boring. Kind of focusing on like, what were you like when you got there? And how are you doing when you left? So I think if you kind of refocus on like, okay, how to make that experience, and when you're talking about the hospitalization experience, okay, well, you showed up and you wanted to be dead, and when you left, you were bored and you wanted to get out and get back to your sports and normal activities. And sort of focus on, well, okay, well, maybe it was boring and you liked it or you didn't like it, but hey, look, you in 5 days, you're, had some pretty significant improvement and change, and kind of focus on those positive aspects. Because that's what we're focusing on. I mean, we're going to do some challenging work, and we want them to, want to be alive, and, or in the case of other patients, not hurt other people. That's what we're trying to do.
And Dr. Douglas, there is another question in the chat here. Does Marillac follow up with patients' families post-discharge, providing caring contacts and or to see if they have connected to a community provider?
We try to make a phone call for patients after they leave. We don't always make contact because we don't always have people who answer the phone. We do, for certain patients, offer follow-up appointments within 1 week, a one-time only a patient appointment to make sure that they're doing okay.
Yeah, so kind of that bridge appointment.
Yeah.
Do offer that and soon, and I think our therapists make phone calls, right? They make follow-up phone calls after patients leave to try to make sure that they're doing okay.
Trying to think other stuff I'm reading by. I'm trying to think, giving like complaints and concerns, and like, cause I know patients leave Marillac and sometimes they're happy, sometimes they're better, sometimes they're worse, sometimes the families are happy with care, sometimes they're frustrated because we couldn't get a chronic problem better in 5 days. I'm trying to think what would be helpful for you guys. Give me something. Come on.
I've actually, I'm a school nurse, Shawnee Mission, and like I'm Allie, and I have actually sent a student to Marillac, and I think the best thing is that the student, as she was a chronic health child of mine, she had some chronic issues, so we were just able to establish a really good relationship with her and her family. And so when we did send them, I was like, can you please release information to me, because I want to help you when you get back, because I know that a 5-day stay is just the beginning of a long road that you have. And I just think when, as a counselor or as a nurse or whoever is doing these assessment on these children, is just being so open with the family and just letting them know that we're part of your healthcare and we're here to help, and that it's confidential. And, I've had to do this a couple times, and I think just being as open as you can with the family and putting yourself out there is a really good way to get them to be able to disclose and share with you. If you're not a stranger walking in, if you're not trying to, be against the parents, if you're trying to work with them. I think that's probably the most important thing we can do as nurses and counselors in a school setting, is an open line of communication, hopefully before we have to recommend that they go to you.
Agree 100%.
And I haven't done this a lot, but I've never had a parent tell me no.
Yeah, I'm sure they appreciate that support.
Yeah.
That can be very helpful. It's really helpful when I think when they agree to do that.
Yeah. And just getting to know them as best you can.
Mhm.
I mean, hopefully this child doesn't walk in your office one day, never on anyone's radar.
This is Brown.
Hi, someone.
That's all I got.
Oh, yeah.
Yeah, thank you for your support in doing that.
Yeah. Allie, did the patient get better? Or we can't talk about patients.
She did. She
Okay.
did get better. She got a
Good.
lot better. And she is, I think, is 6th grade when I sent her. I was in the Shawnee Mission School District at the time, and she's a freshman in high school, and she's doing awesome. And
Good.
yeah, really, really happy.
Good.
It was a lot of past trauma, and
Mhm.
it was nice for her to be able to get the help that she needed.
Good.
Yeah. Good for you, good for her.
Other stuff, questions, thoughts, concerns.
I'll speak up. I'm another nurse in Olathe.
Okay. Oh, so are there more nurses here or school counselors or a little bit of everything? Who knows? Okay.
I had put several questions in the
Okay.
box. Most of it, we have a student I've been working with a lot over the last couple of years that I know has had a lot of contact with you guys. And really, we just try and we're trying to sort out, a big part is like admissions. Like, how do you decide how much to trust the parent versus the kid? Like in our situation, then we're not sure if parents are being fully honest. There's a difference in like what we see at school versus what parent sees versus what we don't know what's going on in your facility, obviously, specifically. Right. We trying to keep in contact, but that's where it gets iffy. Like when we only get so much of the story from parents and we can't get any story from you. And how do we convey concerns in that area to make sure that everybody's on the same page, to make sure that we're getting the best
Is the family allowing
for the student?
Is the family allowing you to communicate with us?
In the past, yes, we've had that HIPAA form signed.
Great. A suggestion. So actually a very real suggestion would be, if possible, and the problem is most admissions occur between 3 o'clock or 5 o'clock and 8 o'clock, which isn't normal working hours. But if there is a time period, I've asked my admissions personnel, like, the patient shows up here, it's not making sense, and the family allows it, we can, I call other doctors, I call therapists. You can call the school and be like, I'm sitting here in this room, mom's here, patient's here, help us, can we do a phone call right now on speakerphone with a therapist? Like, what's your impression? What's going on here? And try to actually have that actual live communication. That's not, I don't want to say that we do that every time, but certainly if there's a patient who's coming through here cyclically, then that may be warranted.
Okay.
So, and that could be a good suggestion to make, when the family's being signed over, hey, make sure they know if you need to call me, give me a call with the assessment team present.
Okay.
So, do you ever get readmissions within 24 hours? Yes. Yes, we do. Or discrepancy discharge assessments versus family patient? Yes. Yes, I do. Yep. Our readmission rate is within 30 days, depending on the month. It's going to be about, I don't know, 6%, 8%, something like that. So, if every, 100 kids, 10 are going to come back within 30 days. A couple of them just come right back because there's some disagreement about whether or not the kid does or does not need services here.
Dr. Douglas, what about families who come to you with whom English is not their first language? How does that work for you all?
We have Spanish language interpreters, which oftentimes will be in the building. I had a Russian language, I've had Russian interpreters, I've had Mandarin, I've had Myanmar dialect. So one thing, so we provide full services. Now, so and kind of, I think to put that in context, we're KU Hospital. We are the exact same tax ID as if you are in the cardiac ICU on the main campus. So we have the same resources that they would have by and large. I mean, we're a different building, but we're held to that same, when COVID hits, I have the same infectious disease people who are doing their protocols, which is why we had to go completely just COVID bonkers and so we have all those things. So just as if you're on the main campus, you're like, oh, there's a patient who is who does not has preferred language is not English, and there's not a licensed individual in that language providing it, then we'll provide an interpreter. I was using a Spanish speaker on a stick yesterday. Very common.
Thank you.
Dr. Douglas, there was also a question in the chat about family sessions. Does the family get to have a session with their hospital
Oh
social
yeah, I'm
worker?
so sorry. Yes, of course. Yes, oftentimes at least one, oftentimes multiple.
Yeah, and typically within the first 24 hours, right?
Generally, although sometimes I wonder if it's better in the first 24 hours or if it's better a little bit later after everything's kind of cooled down.
Right.
Everyone has, when kids go off unit, they have visits with their families every day. There's a movement in psych hospitals to have family rooms so that the families can be in the same room as their child. We are not set up like this right now. We are currently a little bit more of a traditional setup. Child is admitted, child is here, patient's family is not here. Then we do scheduled visits, schedule family therapy sessions more frequently, discharge home.
I did have a quick question. You said that it rarely happens, but like the state of Kansas will kind of bring patients to you, but has it ever occurred where a legal guardian will bring their child to you, but they don't have, by the state of Kansas, they don't have legal rights to their mental state or medical, but they have their legal guardian, but don't have any rights to their medical or mental?
I generally, when I hear a question like that, it makes me wonder what's happening from a legal standpoint. I spend a lot of time looking at consent stuff because consent for treatment, especially if I'm looking at psychotropic medication in children, needs to be really clearly established. We're always going to do what's best for the kid. So if there's a child and then the child needs help, we're going to figure out what needs to happen. That said, generally, guardianship is guardianship. You're either the guardian or you're not. And so I sometimes worry when families like, oh, I'm the guardian. And they're like, well, actually, you're the aunt and the patient's been living with you for 3 years, but no one ever did the legal process to actually take legal guardianship. So the mom who lives 3 hours away, that mom is still actually legal guardian. And I still need to respect that and contact legal guardians to make sure that they're aware of what's going on and act accordingly. And that comes up, stuff like that. It can come up sometimes with police protective custody. It can sometimes come up whether a kid is in custody of the state of Kansas and then KBC or St. Francis or whoever is the designated providers, legal guardian. But it needs to have I always look for a very clear line of guardianship.
Yeah, no, I appreciate that because I had never heard that until this year. I'm a school counselor in Olathe, and I have a case where there is legal guardianship, but the state of Kansas will not give rights over mental health, and I don't know why.
That sounds unusual, and I would certainly, if that were to come through my door here, I would probably get my legal risk to help me clarify very clearly what I can legally not do or not do in that situation.
Yeah, and we do have people that help us with all of that because there are different kinds of rights, and I have seen that too, where sometimes there are rights for different things, for where the child lives, who has educational authority, who has medical authority, and various rights.
But stuff comes up, and that's kind of, now getting a little bit in the weeds, but like, divorced parents, and one parent, wants a child to be on medications, one parent does not. One parent wants a child to be admitted and supportive, one parent does not. It gets complicated.
What do you do in that situation when you do have one parent that wants it and one parent that doesn't?
I try to work with both parents to make sure we can get a point of agreement. My professional opinion is that generally if there's a huge disagreement regarding treatment, and especially if there's a split custody situation, it does not do the patient well to have them switch meds on off between a 50-50 custody situation. And oftentimes the medication ends up being used as a weapon. So I worry about that. Now, it depends on the condition, the patient, and whether or not, the severity of the condition.
Yeah, they can be very complex
It
situations.
gets
that
really
can be very
complicated pretty quick.
Individual. And it looks like we're about out of time. Want to respect everyone's time. I don't know whether Christy or Robert have any, and
Oh, sorry.
Dr. Nelson, who hosted us, have any things they
Yeah,
want.
thank you so much, Dr. Kane and Dr. Douglas, for sharing your insight with us today. We learned a ton about Marillac and the hospitalization process. This is a new topic for us, so we'd love to hear your feedback. There should be a survey in your inbox, and we'd appreciate if you take it. We'll also, after this session, send resources to your email. We'll send out the recording of the session and then some of those phone numbers that were mentioned too. We'll look at the questions. If there were some that weren't answered, we will try and get answers to those and send those out as well. So look for a follow-up email, everyone. Thank you so much for joining.